we gave an award to Choosing Wisely. Choosing Wisely originated from the guilds, egged on by American Board of Internal Medicine and a few other people. But what is the potential for the guilds in the programs like Choosing Wisely to actually really make a difference in cost? And maybe, Mary, you can start with that.
Well, I have great hopes for it. And we partnered with the Medical and Hospital Association with Group Health. We have a task force that Matt served on to think about how we could kind of enliven that campaign, engage the purchasers in that, give them a toolkit. Consumer Reports has developed some wonderful materials that really translate what was initially developed for physicians into what can be advised for consumers. And we are also beginning to measure, using some of those kind of objectives to measure the prevalence of some of these practices in our community. So I think it's a great beginning. And if we can get the consumer to have a conversation with their physician about the need for some of these tests and procedures, then I think it will help, because it's probably hard for the physicians to get too far out ahead of what their patient is willing to do. And so if this can help kind of legitimize some of the questioning about, is this something that's really necessary and is going to help me? So, but these guys are physicians. You have perhaps a better kind of view into that.
I think Mary is exactly right, and the converse is also true. It's difficult for organizations like Group Health or Virginia Mason to get too far out in front of where the leadership of the specialties are in terms of what's appropriate. So I'm a big supporter of Choosing Wisely. I think it's a very important thing. Two things to say. There was an article that was published about 2 weeks ago that pointed out that the procedures that the orthopedic surgeons recommended decreasing are all procedures that other people are doing and getting paid.
Yeah. Yeah.
Is that called the guild mentality?
Yeah, right.
So we got to be a little careful before we get all starry-eyed and rosy-cheeked about just how much the guild-led questioning of guild practices will go up against the sweet spot of their reimbursement. Second thing is, if you look at the fine print of Choosing Wisely, its stated aim, since it comes from a professional organization, is to improve the conversation between patients and doctors. My sense is that the main way in which low-value care will be eliminated is not by improving that conversation, but by eliminating it. So that when organizations install kind of procedures and systems, not to direct someone with uncomplicated back pain to a half-an-hour, $100 conversation with an internist, but rather to a physical therapist immediately, that's the way to eliminate unnecessary x-rays. So I'm very supportive of the ethos of Choosing Wisely, and it gives kind of credibility and gravitas to the actions of organizations to institute systems that can reduce low-value care. I'm a little less enthusiastic about thinking that care will be eliminated primarily by conversations between individual patients and individual physicians.
I heard a conversation at an IOM panel from one of these patient-powered research networks that are coming out of PCORI, where the person stood up and said, I'm confused. You used to tell me that I needed a pap smear every year. Or I had a patient in my practice where this man is convinced he's alive because of a PSA test. And do I tell him now, well, gee whiz, we don't think those PSA tests really are that great anyway. But how do we deal with the changing metric and a public which has been really, in some ways, conditioned to do the right thing, especially around prevention, where I think there's a lot of evidence that over-diagnosis has now emerged as a big issue.
Well, we know how to do this. I mean, when I was growing up, mothers were told, give your kids a lot of sort of bacon and sausage. So we got a lot of bacon and sausage. And then it wasn't until I, was a medical student and saw 30-year-olds in the CCU in Los Angeles that it dawned on me that was probably not good information. So maybe helping educate the Americans that that medical understanding of what does and does not favorably impact health will continuously change, and your doctor is going to and public websites will help you understand the information as it changes. So it's maybe setting an expectation for change rather than believing that that, at any particular point in time, we know what's best, and that science won't teach us differently in the coming years.
Yeah, I think that's right. One of the kind of depressing take-homes of this IOM report is that the amount of American medicine that is actually covered by what we can confidently describe as solid evidence is depressingly small. And I think we've got to have a fair amount of humility about, as Arnie said, the fact that things will change. But here's the good news, or maybe even worse news. I think people don't believe us as much as they used to. People have much greater access to other sources of information other than through interaction with their health professionals. And in this field, as in every other, the disintermediation of professionals, the democratization of access to information, the fact that everybody carries around a medical library in their hip pocket means that people are going to seek out other sources of information. And part of what we need to do is help give them some idea about which of those sources are credible and which ones, Dr. Oz's latest pomegranate juice solution, there's a lot of that too. So for better or worse, that genie, I think, is out of the bottle. And part of what we've got to do is help people curate the sources of information that are much more broadly available to them in health as in every other domain of life.
And is that happening now? Do you think the curation is having a beneficial effect? We hear a lot about literacy, and people's attitudes are very different when they have time to go out and price something versus when they're in that sort of acute, I'm worried, I'm desperate, I just want to be alive, or I want to help my loved one get the best care possible.
My experience is, I still see patients, and I hear doctors complain sometimes about, oh, these patients, they come to me with this stuff from the internet, and I want this and they want that. And yeah, I understand that, and there's some nutty patients out there, like nutty doctors. On balance, I would rather have to walk my patient back from some incomplete or perhaps incorrect information than start with the premise that they know nothing and that I am the entire source of their information. That was never true, by the way. They always had friends and family, but I think in the main it is better for people. We are better served, the patients are better served by sources of information. And over the years, because I've developed relationships with patients, I can say, go to the Mayo Clinic site. They will give you reasonable information on this and that. This site is reliable. That one I'd stay away from. And I think over time, people learn what sources they can trust.
What about the shared decision-making, so-called preference-sensitive care? Is that really just looking backwards? Or, in fact, is shared decision-making one of the ways we have to deal with making better decisions? And that does involve that conversation that Mark says, may cost $100 an hour.
I think the evidence does suggest that it would help. If we were to more routinely do that, it would improve affordability of health care. On average, the research suggests that when you use shared decision-making, which is basically a method of helping patients understand when they're at major, splits in the road between, major treatment options that have significant implications for their quality of life, that if you systematically help people to understand the likelihood of things working out well or not working out well in each of the available treatment paths, and actually give them a sense of, for people who've had good and bad outcomes associated with each treatment path, what life is like for them, then on average, they are, compared to their doctors, less inclined to select the more aggressive, higher risk treatment, higher cost treatment option. And the center of that evidence suggests that they will opt for the more conservative approach relative to their doctors at a frequency that's result in a reduction in service volume of about 20 to 30%. Now, that's it's interesting. It's been around for a while, but it's not something that health systems have rapidly took up. It's partly because even in systems like Kaiser, where the doctors won't be paid more or less depending on the patient's decisions, it really represents doctors giving up a role they've traditionally enjoyed, which is as the trusted advisor to the patient. It's basically saying you really should. I'm going to help you make the decision yourself rather than me as your trusted advisor, make this decision. So it's been hard for physicians to be fully supportive of this, and so it's not caught on as quickly as I think it should. But I think the comments that Mark made earlier are right. If you begin to, change the incentives and teach, nurses and doctors and patients for that matter, about, these mechanisms we know about that would improve healthcare affordability and probably improve quality, that it could be accepted and more widely used.
I think the common thread between the choosing wisely and shared decision-making is the importance of the communication, the quality of communication between the patient and physician or their provider. And I know we've just repeated for the second time a patient experience survey, sent out surveys to 120,000 people, had almost 30% response rate. And what we found, not surprisingly, is the key driver of higher satisfaction is the quality of communication, the ability of the provider to communicate with the patient. And that if they do understand what the, what's expected and can communicate effectively, they're more apt to adhere to the regimen. And actually, UW Network, UW Neighborhood Clinics saw in their first survey that they came out average, and they felt like they weren't average, and so they had a concerted program, a process improvement effort to improve their communication, and voila, they were in the top 5 clinics who came up with, being in the top, above average in all the areas. So I think the power of the patient-physician or provider relationship and the quality of communication is a key thing, even in an environment where more and more things may be self-care, but you want those interactions that are personal to be really high quality, high value.
Well, a shout out to David Arterburn and several of the, I'm sure, people in this audience, the group health specialists have worked with David and the Foundation for Shared Decision Making, and we have a widespread use now of shared decision making for at least 12 preference-sensitive care. And I think the evidence is, as Arnie said, it really does often lead to something that's more appropriate for that patient. Less is more, if you will. But the key thing is it broaches a way of communicating that is really important for all of us.
So I think we're on the cusp of a major improvement here, because one of the things your audience may not know is that in the last 3 years, there's been an investment in this so-called patient-centered outcomes research field. The fact of the matter is we know a lot about morbidity rates and mortality rates. We often don't know what kind of side effects or benefits are most important to patients. And so if you're having a discussion with a patient about alternative approaches and you can't tell them the likelihood that they will develop incontinence or impotence or have a skin burn, then you're left talking about the stuff that is important to doctors. So to the extent that we get much better about knowing what outcomes are of importance to patients, having this conversation about their preferences can be a much richer conversation. It's not information that we've had in the past, and we're just beginning to kind of do that. So that, I think, will lead to a major increase in our capacity to have shared decision-making about decisions that are powered by things that are important to patients rather than things that are just kind of important to us.